Hello, and welcome to the lecture on trauma and stress-related disorders. For today, we're going to talk about, all of the disorders related to trauma and related disorders for the DSM for that specific chapter. We're also going to, before we get into all of these disorders, we're going to define and describe trauma and also crisis, because crisis and trauma can be said in the same breath at times. They are a little bit different of things, but we're going to cover those two concepts before we get to the main traumatic disorders, which there are 5 of them, which is reactive attachment disorder, disinhibited social engagement disorder. Both of these disorders are more childhood related, or at least can begin in childhood. For the school counselors and the pediatric clinical mental health counselors, you want to pay extra special attention to them. Post-traumatic stress disorder, I guess, could be more, a childhood disorder, but also an adult disorder as well, as is acute stress disorder and adjustment disorders. I gotta say, maybe all of these disorders could be had in childhood, adolescence, or adulthood. So maybe they transcend the lifespan. And then last, we have other specified trauma and related disorder. So why don't we get started? So I somewhat, I guess, fancy myself a bit as a trauma therapist, trained in EMDR and practiced for several years as a trauma therapist and EMDR therapist. And I've written a couple of articles about trauma, and one of the things that really got me was the lack of definitions of what trauma actually is. And for a while, I was using this really mild definition of trauma that didn't fully encompass what trauma was. I did find one on the SAMHSA website that is a little bit more comprehensive and broad-based. So I'd like to define trauma from this perspective. Trauma relates from an event, a series of events, or a set of circumstances. So it can be one event, several events, or a set of circumstances that is experienced by somebody as either physically or emotionally harmful. Now, I think that's important, that trauma isn't necessarily just physically harmful. It can also be emotionally harmful as well. Or threatening. So it doesn't have to be directly harmful. It can be harmful or threatening. And that's what I like about this part. It can be physical and or emotional, and it can be harmful and or threatening. So I like the way that trauma is, the definition has been expanded out even further. And in addition, it's going to have lasting adverse effects on the individual in terms of their functioning. That could be physical functioning, social, emotional, or spiritual. So there's a lot of dimensions that this definition of trauma is mentioning that can be affected by the trauma itself. So this is one that I really find to be the most encompassing to date as far as my research on trauma has been. So I want you to think about trauma in terms of this definition, in terms of and how it can manifest from this definition, and also be very can impede functioning on a number of levels based on this definition. Now, I'd like to speak a little bit about how trauma might work in in a person in terms of how the functionality of it. And what I'm going to talk about is the adaptive information processing model, otherwise known as the AIP model. Now, this model, let me just say this. This is a model that can explain how trauma works. It's not the model. It's not, it's like a theory of counseling. It's a way of looking at something. So the AIP model is a way of looking at and explaining trauma. Now, research has not substantiated this model, but research has also has not proven this model to be incorrect. So because neuropsychology simply does not have the equipment and the technology to test this model and prove it to be correct or incorrect. So the AIP model is more of a cognitive psychology model in terms of how memories consolidate into long-term memory and how we store memories in the brain. And I'm just going to give you a general spiel about how this works is that every day we walk through life and we experience a number of things, events and conversations and whatever. And at the end of the day, we go to bed at night and as we sleep, our brains will take the new information that is learned from that day and consolidate it into long-term storage through the working memory of the hippocampal region of the brain, and it stores it into the association cortexes of the brain. I think a lot of that is when we go through REM sleep, that the brain is working to take that new information, attach it to old information, and that's what we keep in our memories. Now, sometimes we have a bad day, and let's say you get yelled at by the boss at work, and you're just not feeling good about it. You go home and you talk to your spouse or your partner or your friend about about your day, and you're working it out, through the social interaction of just talking about it. And they'll say, well, go ahead and sleep on it. You'll feel better in the morning. Well, that might just be a saying that we tell people, but it's actually kind of true, because when you go to bed at night, that memory, whether it's a bad memory of getting yelled at by the boss, or a good or any just benign memory, as it consolidates into long-term storage, how it's doing that is the brain is neurologically connecting that memory of being yelled at by the boss with other memories within the brain that can be seen as resourceful. So what it's doing is it's maybe taking that bad memory of, I got yelled at by the boss, and it's pulling another memory within the brain that, hey, last year you got employee of the month, or maybe you got a 4-point average in graduate school, or even something as abstract as or as unrelated as, when I was 8 years old, I went on vacation with my grandparents and it was a really good time. So it takes resources, positive memories, and attaches to that negative memory, and what it does is it almost like it metabolizes that bad memory, or that bad event, and it makes it not seem as terrible. So when you wake up in the morning, you kind of think, well, I slept on it, I feel better, having a new perspective on things. Everybody gets yelled at by the boss once in a while. This was just my time too, and quite honestly, I think they had a point, and I'm going to take what they said and I'm going to learn from it and move on. And then that memory is now something that we can make better decisions for in the future. So the problem is during a traumatic event, that those memories do not consolidate into long-term storage. They cannot, whether it's some kind of whether that memory node is so toxic because it might be saturated with the stress hormone of I can't remember the stress hormone name, or norepinephrine, or whatever, that maybe it is neurochemically toxic and cannot connect with other memories, or the brain can't figure out which memories that would be resourceful enough to connect to that memory to make it metabolizable, or to make it consolidatable. So problem is, so that memory is like, it sticks out like a thorn in our brain, and it doesn't metabolize. It doesn't move into long-term storage. We can't gain any resolution from it, and it remains triggerable. That anytime that traumatic memory activates, all of the thoughts and the feelings and the somatic reactions that are associated with that memory can activate, and sometimes we can even experience a reactivation of the entire memory, where we feel like we're living through it again. And so the brain just does not have the capability of healing itself to and pushing that memory through, and making it consolidatable, and achieving a sense of integration. So, and thus, that's when trauma symptoms start, when people are triggered and people try to avoid triggering themselves, and they go through the process of all that. So this is just one one aspect of, or one model that tries to explain why trauma happens in the brain and the functionality behind it. And it's one that I subscribe to because the AIP model is the foundation model for EMDR. So, and if you want to learn more about that, the trauma counseling course does go into some pretty good detail about this model and about EMDR in general. So, all right. The impact that trauma can have on people, that it can serve as the etiology of a number of disorders, like not just any of the disorders of this chapter, such as PTSD or acute stress disorder or reactive attachment disorder or adjustment disorder. It can also serve as, an etiological piece of anxiety disorders, depressive disorders, substance use disorders. That, think about substance use disorders. Think about how, if somebody experiences traumas from their past and they're triggered by those traumas, that they might try to self-medicate by using alcohol or marijuana or whatever in order to, soothe those trauma triggers. And maybe drinking at one point was maybe a coping mechanism that worked, but unfortunately, if your tolerance goes up and your withdrawal symptoms, might come out from that, then you might be facing a substance use disorder that can become unmanageable. Also, the impact of trauma can exacerbate existing disorders, so it can actually maintain mental, emotional, and substance use disorders. Because if they're part of the etiology of that disorder, if that trauma is not resolved, those disorders will remain active and vital, or even a relapse of mental, emotional, and substance use disorders, that maybe you got over your anxiety or your depression at one point, but the trauma is still there. And when that trauma is reactivated, those old symptoms of anxiety or depression might come back, or people might relapse in a substance use disorder that if somebody is re-triggered again or re-traumatized, that they might go back to an old way of coping that can that can lead to use again. And I think more generally, I think we can combine these two, that it's really an interplay between the etiology and the exacerbation of mental, emotional, and substance use disorders. So it's not just the cause or the maintenance or relapse of it. It's both. It's a little bit of everything. And I think when we do diagnostic assessments on folks and we're thinking that, hey, this is maybe a substance use issue, definitely check in for trauma, because trauma can serve as the etiology of the substance use, and it can serve as the functionality and as maybe an exaggerated coping mechanism through a substance use issue. Same with mental and emotional disorders as well. So, I can't underplay. I can't describe enough how much trauma can really contribute not only to PTSD and the disorders of this chapter, but all of the chapters of the DSM. So, okay. Also, crisis. I'm sorry, I went too far on the slide. Okay, so next let's look at crisis. Crisis defined is, and this is a very simplistic definition of crisis, because I'll be honest with you, I don't know as much of the literature on crisis as I do trauma, but I did want to include it here because I think it's important. Crisis is, in a very general sense, it's a time of intense difficulty, trouble, or danger. So there's a lot of different ways that we could take this. Also, there's a general level of instability during a time of crisis, dysregulation, emotional dysregulation, cognitive dysregulation, somatic dysregulation, and also just general uncertainty that people might not be able to see a clear way out of their predicament and see a clear way to their future, which might cause a lot of emotional distress. And like I said, this can affect us cognitively, emotionally, and somatically. Now, from when someone's having more of a psychological crisis, it's this is a time that it's more temporary. It passes with time. I worked as a crisis interventionalist over a phone crisis interventionalist after college for a couple of years, and people would call, and if they were in a general state of crisis, we would help talk them through that, and find what things that they could do that night to stay safe, and also to self-soothe, until until they could feel a little better. Because typically, this is like a time that people crisis, is a time that people like their psychological crisis spikes, and they feel a great amount of emotional distress for a short period of time until it kind of goes away. The impact of crisis, once again, if this can exacerbate existing disorders. So if this is, if somebody has some kind of a mental, emotional, or substance use disorder, that if they're in a state of crisis, for more times than not, or going in and out of crisis, that this could help maintain these disorders, as well as possibly even relapse back into a disorder. So, for example, with the substance use disorder, that if somebody has been sober for let's say a few months, they're trying to work on their program, and they go into a state of crisis for whatever reason, whether it's interpersonally related or what, that they go in and they experience a very immediate and sudden emotional distress, psychological distress, that might be enough for them to relapse and start using again. So crisis is, once again, very important in terms of, and it's not just for these disorders that we're discussing for this lecture. It's for anxiety disorders, depressive disorders, psychotic disorders, substance use disorders, any of them. In the DSM, that crisis can trigger these again and get them started, or even help maintain those symptoms. Crisis can also lead to poor decision making if they're in a very bad way, or in a very dark place, for a moment in time, that they could make a questionable decision to do something very, very drastic. Suicidality is something that you certainly want to assess for when somebody's in a state of crisis. All right, so reactions to trauma. People can react in a lot of different ways to trauma, and I think I've already kind of said this, or I might just reiterate in a different way. This is really more than what the DSM reports. I'm of the opinion that trauma can serve as the serve as an etiological piece of the puzzle to figuring out where somebody's anxiety disorders come from, the depressive disorders. Aggressive based types of disorders, or externalizing. Like when I think of intermittent explosive disorder, I think okay, was there trauma behind that served as the etiological factor for impulsive explosive disorder. So the thing is that everyone, well, I won't say everyone, but a lot of people experience trauma. And how we react to those experiences is going to be very vast and very different. All right, so let's move on to reactive attachment disorder. This is, well, like I said, one of the ones that's maybe a little bit more associated with during childhood. It's an easy one to code, F94.1. And this is a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers. And you need both of these criteria in order to qualify. That the child will rarely or very minimally seek comfort when distressed. So their attachment level is, their attachment style is going to be insecure. In terms of when they're in distress, if you have a secure attachment with somebody, or a secure attachment style, you will run to the person that you're attached to for comfort. These kids do not have a secure attachment, so they're not going to go out looking for people, looking for that attachment figure when they're upset. Also, the child is rarely or minimally going to respond to comfort when they're distressed. So they're not going to go looking for it, and they're not going to respond to it when it's offered to them. That they just don't have that capability of looking for it or even receiving it when it's given to them. There also has to be, for criterion 2 or B, persistent social and emotional disturbance by 2 or more of the following. That they have minimal social and emotional responsiveness to others, so that they're not going to be super responsive to other people. They're going to have a limited positive affect, so they're not going to be the happiest of children. Also possible is the episodes of unexplained irritability, sadness, fearfulness that's evident even during non-threatening interactions with caregivers. So when something bad's going on, they might be exhibiting these things. When nothing is really going on, they might be exhibiting these things. So it's really unexplained. Like, why are you so irritable? Why are you so sad? Why are you so fearful? Well, that might just be their general emotional state. Okay, criterion C is the child is going to experience a pattern of extremes of inefficient care by 1 or more of the following. So this is kind of the etiology of, okay, why are they experiencing criteria A and B? Well, this is most likely the reason, and they have to have experienced at least one of these. That they've experienced social neglect or deprivation, persistent lack of emotional needs for comfort, stimulation, and affection by caregivers. So they're not getting loved by their caregivers, or they experience lack of love by their caregivers in the past. Also, repeated changes of primary caregivers, which is not giving them the opportunity to form attachments. So they might have been passed, from mom to dad to grandma to aunts, uncles, that the caretaker just keeps getting switched up on them. Also, the rearing in unusual settings that might limit their opportunity to form attachments. Like, these kids might grow up in the foster care system, where they're not being able to really, develop attachments with somebody. Now, we have to be able to point to for criterion D, we have to be able to point to criterion C and say it's responsible for A. I hope that makes sense. Also, for E, the criteria that we have to rule out autism, because there's some things about reactive attachment disorder. I'm just going to call it RAD for now. There's criteria about RAD that could point towards autism. So we have to make sure that we rule that out. The disturbance has to be apparent by age 5. So someone who's 10 or 15 years of age who are developing these symptoms, that is not going to be RAD. That's going to be something else. So they have to develop the symptomology fairly early in childhood. Also, the child has to have a developmental age of at least 9 months of age. Specifiers that they can be persistent in symptomology, that the symptoms have to last at least 12 or more months. And also, you can have the specifier of severe, which means that all criteria are present and at a high level. Some diagnostic features and also associated features for RAD is that, just generally, you're going to see this underdeveloped attachment style between them and their caregiver. They're not going to utilize their attachment figure or their primary caregiver for comfort, and they're not going to really like it when they're comforted. It's thought they can form selective attachments when they want to, but they're going to be very guarded. Absent expressions of positive emotions. So the thing is that you can try to joke around with them or play with them and see if they have positive affect or they can feel happy, and it's going to be somewhat absent. So if you're working with these kids, you might want to try to play a game with them, or tell them jokes or something to see, can they move out of that negative emotional state. Their emotional regulation system is going to be compromised, and mainly because that we know that emotional regulation comes from securing an attachment with your primary caregiver, And if you can do that, then your emotional regulation will be stronger. But theirs is compromised, so they're not going to have the ability to regulate their feelings. This can also co-occur with cognitive and language delays as well. And also you might see signs of malnutrition or poor care because, so you want to look into, if they've been neglected. Prevalence is unknown for RAD. We don't know how many kids really have this disorder. It's typically found in children exposed to severe neglect, but only less than 10% of cases are exposed to severe neglect. So prognosis is somewhat related to quality of caregiver following neglect. So if you can pull them out of their neglected household and begin to give them some consistent attention and care, then then they might come around a little bit better. The onset is going to be between 9 months to 5 years of age. It's unclear if it's present in children older than 5. If you can diagnose that. Also, it's going to definitely lead to interpersonal problems with other kids and adult figures. Differentials that you want to rule out: autism, intellectual disabilities, and depressive disorders, especially DMDD, because that is a childhood depressive disorder. But it can be comorbid with depressive disorder. So if they do have DMDD and reactive attachment disorder, then please diagnose both. So next we have disinhibited social engagement disorder, which is coded F94.2. So once again, this is another easy disorder to code because it's not reliant on specifiers and subtypes. If you think about RAD being on one extreme of the continuum in terms of engagement and attachment and how they express that, disinhibited social engagement disorder is the bipolar opposite of RAD. And the behavioral patterns of kids with disinhibited social engagement disorders, when a child might approach and interact with unfamiliar adults, in 2 or more of the following ways. So, they're going to have a reduced or a complete absent reservation in approaching and interacting with unfamiliar adults. So a kid with RAD would never approach an adult like this, that they don't know. Whereas these kids will just walk right up to an adult and interact with them in a very casual and way where they're not nervous about that. They're overly familiar. They have overly familiar verbal and physical behaviors. The diminished absent, or they have a diminished or absent checking back with adult caregivers after venturing away in unfamiliar setting. So if you put this kid out, if you bring this kid to maybe some kind of a party or something, that this kid will just bolt from their caregiver and they will look around and they will just explore and do, and they just don't know or care really where their caregiver is. And they might be talking to other adults, and engaging in conversations with very little hesitation. These kids have a willingness to go off with unfamiliar adults with just no hesitation or very little hesitation. So these kids might go to a party and leave their caregiver and go to another adult and say, "Can I come home with you? Will you be my new dad?" So it's very different from RAD kids, because kids with RAD will, they don't really seek out people and they don't really want people comforting them, where these kids are starving for it and they're looking for it in just about anybody. Criterion B is behaviors of criterion A are not limited to impulsivity, but really include socially disinhibited behavior. So you have to remember that there are some disorders, like maybe ADHD, where these behaviors might be seen as being, hey, these kids are impulsive. These kids are not being impulsive. They have differing attachment styles where they don't have many boundaries. Criterion C is the same in disinhibited social engagement disorder as it is in RAD, that the child has to have experienced a pattern of extremes of inefficient care by one or more of the following: either social neglect, or deprivation, repeated changes in their primary caregivers, and their rearing has been done in unusual settings that might disinhibit them or might limit them to form healthy attachments. So it's really, they're responding to this inefficient care in just the bipolar opposite way as a child with RAD would. So once again, these criteria are pretty much the same as RAD, that the criterion C is responsible for criterion A, and the child has to have a developmental age of at least 9 months old. Specifiers are the same. Diagnostic and associated features of this disorder is that they're going to have overly familiar behavior with strangers that violates social boundaries. So these kids might just walk right up to a stranger and hug, an adult, and hug them and tell them they love them and ask them, will you be my new parent? Or lead them around and and show them around, or whatever. But it's not typical to what kids the level of comfortness or level of comfort that children have with adult strangers. They could present with cognitive and language delays, same with children with RAD, and also malnutrition if they're being physically neglected. Symptoms may still be present after the above are resolved. So attachment to caregivers might be lacking, disturbed, or secure. Prevalence is unknown in terms of how many children have this. It's somewhat rare, but it is seen. It's seen in 20% of severely neglected children. During preschool age, verbal and social intrusiveness and attention-seeking behaviors are apparent. With young children, there's no fear in approaching and engaging strangers. And then by adolescence, that they really have superficial peer relationships, that they don't know how to develop a sense of intimacy, emotional intimacy with friends, and secure attachment with friends. Risk factors and functional consequences of this disorder. They can have serious social neglect. The prognosis is going to be somewhat associated with caregiver quality after the neglect. It's kind of like RAD, that if you can pull them out of that bad situation and give them, love and care and attention, then you're going to have a better prognosis. This will impair the child's ability to relate interpersonally to peers and adults. So even though they seem like they're very friendly and they're this is affecting their ability to really connect with people. Differentials in comorbidity, you got to rule out ADHD. However, if ADHD is also if those symptoms do qualify them with ADHD, then they could have both disorders. Okay, let's move on to post-traumatic stress disorder. I've included 2 YouTube depictions of PTSD on the Moodle page. So if you haven't watched that, I would pause this lecture and watch that, because it's going to give you a little bit better description of what PTSD is. PTSD is another easy, and I'm just calling it PTSD because it's easier. It's an easy one to code, F43.10, because it doesn't rely on specifiers or severity levels. It's just one code. But PTSD, let me just say this: the coding does not depict how incredibly idiosyncratic post-traumatic stress disorder can look for one person. There's a wide variety of ways that PTSD will present itself. So you could have 10 people with PTSD. It's going to look different for each one of them. So please know that. The first criterion is about exposure to an actual or threatened event. So it's exposure to an actual or threatened death, injury, or sexual violence in one or more of the following. So, and this is important to know, that the first one was if they directly experience the event itself, then I think that goes without saying. maybe they've witnessed the event happening to somebody else. So maybe they witnessed an accident or an assault or a murder or something that they saw this traumatic event unfold. Or they learned the event happened to a friend or a family member. So I kind of think that this third depiction is that you have a strong attachment to somebody, and if they've been hurt or killed or in some way, that attachment, that sense of emotional attachment to them can traumatize you because you're so close to them and attached to them. So I think that it goes back to that attachment issue. Also, the fourth one is if they experienced repeated or extreme exposure to adversive details of the event. So if they grew up in a family that's experienced a trauma, maybe like more of a global type trauma, and they keep being told stories about this trauma as they're growing up, they can develop post-traumatic symptoms from that. Now, let me also just say right now that traumatic events are subjective, and responses to traumatic events are subjective. That two people can go through the same traumatic event. One person can come out completely unscathed, and the other person has all kinds of PTSD symptomology. So just because two people experience the same event does not mean they're going to react to it in the same way. And I think part of it might go back to having a genetic resilience to trauma, possibly a psychological resilience to trauma, depending on how many psychological resources they have, maybe psychosocial resources they have. So it's not as it's complicated. I think is what I'm trying to say. Okay, criterion B. This is the presence of one or more of the following intrusive symptoms associated with the event. So this is about intrusive symptomology, that they have recurrent, involuntary, and intrusive recollections of the event. Like they might have images popping up in their heads, thoughts about the event. They might have recurrent dreams. They might wake up every night dreaming of the event. They might act or feel as if the event is reoccurring, like I'm having a flashback and it's happening all over again in real time. And part of that is due. I'm not going to get too much into this because it's gone over in the trauma class, but it's mainly about that the thalamic rhythms in the brain and how the thalamus is acting out of rhythm, and you do have these misperceptions of time that you could be triggered on a traumatic event and it's actually coming back and you're remembering it as if it's really happening. So it's really interesting how the brain works. The fourth one could be intense distress when exposed to an internal cue or an external cue that symbolizes or resembles the event. So maybe somebody who's maybe fought, in the war, that when they see people who are in uniform, that might be triggering, or if they watch war movies, that might be triggering, or just internal cues when they think about the event, that it can, it can be very triggering. And then the physiological reactions when they're exposed to the internal or external cues that symbolizes or represents the event. So what that is the physiological reactions is the somatic reactions related to when they're triggered, that their sympathetic nervous system will fire and they will go into a fight or flight mode and possibly experience panic-like symptoms or something related to that their body, whatever the trauma is, the unprocessed trauma, when it triggers, they experience a somatic reaction to that trauma, and that's very common with trauma. Okay, so criterion C is about the person's attempt to avoid stimuli that's associated with the trauma in one or more of the following ways. They either avoid or efforts to avoid memories, thoughts, or feelings related to the event. So they just try to block anything related to the trauma out of their thoughts, out of their heads. They don't think about the memories related to it. They just block it out. Or they avoid or attempt to avoid external reminders that will once again arouse distressing memories, thoughts, or feelings related to the event. So if they were in an accident on a specific road and they were traumatized by the accident, maybe they won't drive down that road. Maybe they will go and they'll go all the way around town just to avoid that road, going up and down that road. That they do not want to be triggered by that. Okay, criterion D is are the negative alterations in cognitions and mood that's related to the event by two or more of the following. So this is, once again, how they're thinking and how they're feeling is affected in negative ways. They might not be able to remember important aspects of the event, so they've maybe blocked it out or disassociated. That they have persistent and exaggerated negative beliefs or expectations about themselves, others, or the world as related to the event. So they're so based on that trauma, they've begun to develop negative concepts and worldviews about self, others, and the world. Persistent, distorted cognitions about the cause of the event that leads to self blame. So these folks might start to get into their heads that, well, it was all my fault. If they were in an accident, they were in the back seat, and let's say everyone in the front seat died, they might like ruminate about how it was all their fault, that everyone in the front seat died, that they should have been in the front seat, or at the last minute they got put in the back seat, and they're blaming themselves for being alive, for their friends being dead. They also have persistent negative emotional states, so it's really hard for them to get out of their depression or their anger. They have a diminished interest in activities. So once again, that anhedonia coming out, they're just not interested in doing fun things or really anything at all. They also start to feel detached and estranged from other people, that they start isolating themselves, like nobody understands me, and maybe just a lack of interest in being around others. And they have a hard time experiencing positive emotions in general. Okay, criterion E. This is marked by alterations in arousal and reactivity related to the event in two or more of the following ways. This is a very involved diagnosis of PTSD. So they might be irritable, they might have irritable behaviors, angry outbursts. They might be physically or verbally aggressive. They might be reckless in their behaviors. They might be showing self-destructive types of behaviors, and that could be a number of different things. They might be hypervigilant to whatever, to their surroundings. They might also have an exaggerated startle response, problems concentrating, and also have a hard time sleeping. Excuse me. Criterion F, the duration of criterion B through E has to be going on for at least 1 month. So as we're going to talk about acute stress disorder, if somebody's been diagnosed with acute stress disorder, usually that only goes up to 1 month. And once the symptoms last longer than a month, they will graduate up to PTSD. So these symptoms have to be going on for at least a month. And goes without saying, criterion G, this is going to cause significant distress in their life and also impairment in a number of dimensions of their life. They might not be able to go to school. They might not be able to work. They might have a lot of problems with their relationships with other people. Also, you have to rule out substance use and a medical condition that might better explain these symptoms. There are specifiers, but they're not related to the coding, so that makes it a little easier, that they can be with dissociative symptomology, but they have to meet the criteria for PTSD in order to have this specifier. So they might have feelings of depersonalization or derealization. Depersonalization, we're going to get to that in another lecture, but depersonalization is they have feelings, they feel detached from their body. They feel like they're in a dream state. Like maybe everything is, maybe in slow motion. Same with derealization. They have feelings of unreality. They have experiences that are dreamlike or distant, like they're just not feeling connected to themselves, that they go into a state of hypoarousal. So the thing is PTSD, I think, is associated with being in a state of extreme hyperarousal, whereas dissociation is when you go into a state of hypoarousal. But you can have PTSD and feel in an extreme state of hyperarousal and also have some hypoarousal. You can, wait, let me say that again. You can be diagnosed with PTSD, which is associated with being in extreme states of hyperarousal, but then still have these specifiers of dissociation where where you're experiencing a state of hypoarousal. With delayed expression, typically the symptoms are going to develop 6 months after the stressor. So with trauma, sometimes trauma doesn't hit us all at once. Sometimes for whatever reason, our defense mechanisms can hold back the trauma reactions until a later time when we're safe enough to start dealing with them, and then symptoms of PTSD can emerge. So that's important to know. Some differentials to rule out. There's a lot to rule out when looking at PTSD. You want to make sure, first off, that they meet the full criteria for PTSD, and if they don't, you might be looking at other specified trauma disorder. Adjustment disorders. I think when somebody, we haven't talked about adjustment yet, but when somebody is faced, with life transitions that they have to adjust to, that is a trauma in and of itself, but it's not to the extent of severity of PTSD. So you have to look at is it a traumatic event that they've gone to that meets the, for criterion A for PTSD, or is this like, hey, life things are happening to me, and like, I got fired, and I got to get another job, or I got to move across the country, and I'm having a hard time adjusting to that. Now that can be traumatic, but just not to the extent of PTSD. Acute stress disorder, that's going to be much more, I guess, acutely based on trauma. And we'll talk about the differences between that and PTSD when I get to that. We have to look at conversion, dissociation, personality disorders, OCD, anxiety disorders, psychotic disorders, and traumatic brain injury. There's so much to rule out. So when you assess for PTSD, you have to make sure that you're ruling out all of these things and that you're getting the diagnosis correct. However, comorbidity, that anxiety disorders, depressive and bipolar disorders, and substance use disorders are all comorbid with PTSD. So if they have any of these disorders and the symptomology is independent from PTSD, then diagnose both. The etiology of PTSD is that somebody has to have an exposure to a traumatic event. That's going to be the main etiology. There's going to be biological and psychological vulnerabilities. Like I said, some people are going to have certain vulnerabilities to PTSD, and other people are not. That if you have a family history of anxiety, if you have positive coping strategies, seem to be a protective mechanism against PTSD. Personality traits, if you're anxious, have minimal education, can predict exposure to traumatic events, which in turn predict increased risk. Higher intelligence predicted decreased exposure to traumatic events, and possibly, I've always seen in my anecdotal evidence is that people that come in with trauma who have a higher level of intelligence respond better to EMDR therapy. I don't know if there's research to substantiate that, but what I have found in my own clinical practice is that if you have a higher intelligence or a higher IQ level, then you will be able to process trauma a little bit easier. Social and cultural types of variables. If you have support systems, a strong support group, you have less likely to develop PTSD because you're able to maybe talk some of these things out and seek emotional support. All right, so the neurological mechanisms of PTSD. Researchers have shown that PTSD can involve several neurobiological systems, but also, I think one of the things that I find fascinating is the damage that it inflicts upon the hippocampus, especially with chronic types of PTSD, like with war-related survivors of sexual abuse, firefighters exposed to extreme trauma. That the hippocampal regions of the brain are actually ablated or reduced. And if you don't remember, the hippocampus is in the limbic system of the brain, and it's responsible for short-term memory and the consolidation, helping to consolidate memories into long-term memory. So when I think about the AIP model, I think about how these memories, these traumatic memories, maybe get stuck in the hippocampal regions of the brain because of the neurotoxicity, such as cortisol levels, norepinephrine levels are really high, and which might be inflicting damage upon the hippocampal regions. Now, of course, that's just me somewhat theorizing based on the research and also the trauma models, but that could be a possibility. So disruption also, the ablation in the hippocampal regions can lead to short-term memory and loss and recalling events. Also, I want to say that, and it might not be on this slide, but trauma can affect the amygdala of the limbic system, which is responsible for rage responses and aggression. So, treatment for PTSD. Really, the psychological treatments are going to be facing the trauma in some way, to develop effective coping procedures. Like some, I guess it depends on what kind of therapy you're using, because some therapies will address the trauma head on, verbally. Others will address the trauma head on non-verbally. Others will not address the traumatic event, but talk about ways of coping with the event and working and just living with the trauma and in life. So I guess it really depends on how you want to go about treating trauma. The thing I like about EMDR, and I guess I'm just going to get on my own soapbox on this one, is EMDR does not require the person to recollect to their trauma in any great detail. That actually there's very little getting back into touch with the traumatic event at all, other than to map the trauma. And then when you start processing it, all you do is briefly activate that memory, and then you begin the actual treatment. And there's no needing to describe the trauma, because I think it's somewhat unethical or malpractice to have people just come in and talk about the details and ins and outs of the traumatic event over and over, because all that does, I think, is re-traumatize them, and it doesn't actually help them to resolve the trauma. So, I mean, but that's my stance on things, and there's a lot of different other models of trauma that are out there that could that are also helpful. The pharmacological treatments are typically going to be either antidepressants or benzodiazepines. Antidepressants are going to relieve the severe anxiety and panic attacks, whereas benzodiazepines is going to help relax the person in that moment. Like if they're just feeling really stressed out, Xanax will take the edge off. All right, so that does it for PTSD. Let's move on to acute stress disorder. And acute stress disorder has another easy F code, F43.0. So it's very easy to code. You don't have to worry, once again, with with severity types and or anything like that. The first criterion deals with the exposure to an actual or threatened death, injury, or sexual violence in one or more of the following. So it's pretty much the same. The same criterion as post-traumatic stress disorder, that they directly experience the event, they witness the event, they learn that the event happened to somebody that they're close to, or it's the experience repeated or extreme exposure to adversive stimuli of the event. So criterion A for acute stress disorder, which I'm going to probably call ASD from here on out, and PTSD are synonymous. Now, where they differ is criterion B, which is the presence of 9 or more of the symptoms from any of the 5 categories. And the categories are pretty much maybe the same, but it's just kind of maybe shuffled around a little bit. So the first category is going to be the intrusive symptomology, recurrent involuntary and intrusive memories of the event, recurrent distressful dreams about the event, dissociative reactions as if the event feels like it's occurring over and over. So that's that thalamic misfiring. The intense or prolonged distress, physiological reactions in response to internal, external cues to the event. So they will have extreme distress, emotional distress, and or physiological reactions related to the stress. So, or related to the event. So, but in my experience, the emotional distress is always hand in hand, or 9.5 out of 10 related to the physiological reactions. Negative mood state, persistent inability to experience positive emotions, dissociation symptoms such as having an altered sense of reality, feeling dazed, time slowing. They can't remember aspects of the event. A lot of this is very PTSD-like. Avoidance symptoms, having or efforts to avoid distressful memories, thoughts. They don't want to think about the event. And then the 9th criterion is they actively avoid external reminders of the event that will cause the triggering of the memories, thoughts, feelings. So arousal symptoms, they could have sleep problems, irritability, angry outbursts, hypervigilance, problems concentrating, exaggerated startle responses. So a lot of this is pretty much the same as PTSD. Here we go with a differential. What's different is criterion C, that the duration is going to be 3 days to a month after the trauma. So if somebody experiences a traumatic event that after 3 days, they're going to start experiencing these symptoms up to a month. After a month, if these symptoms go away, then acute stress disorder, that's what it was, and it resolved itself. But if they continue on, then they're most likely going to graduate up to PTSD. This is going to cause them clinically significant distress and impairment in different areas of life. And of course, we have to rule out substance use, medical conditions, or even a brief psychotic disorder that could better explain these symptoms. Differentials to rule out are pretty much going to be the same as PTSD, the differentials for PTSD. So it's fairly, I would say, ASD and PTSD pretty much are along the same lines in terms of when you do diagnostic impressions. The treatments is really going to be the same as PTSD. And it's just really going to depend on what your orientation is. Group therapy can be good because it can bring about a sense of normality, that everyone's in the same boat. There's the imaginal exposure therapy, if appropriate. I would guard against that because that can be very traumatizing if not done correctly. Cognitive therapy can work. EMDR is that's going to be my go-to because I'm an EMDR therapist. So I guess I have to be transparent about that. Okay, next we have adjustment disorders. Now, adjustment disorder, I think, is appropriately placed in the trauma chapter, as I think most psychological disorders of the DSM should be in the trauma chapter. But adjustment disorder is part of this. And this is when people develop emotional or behavioral symptomology in response to some kind of a stressor in life that occurs within 3 months of the onset of the stressor. So the stressor, of course, can be very traumatizing in its own sense and create a state of crisis for the person. And the symptoms are going to be, of course, significant, clinically significant, evidenced by one of the following. Either one, or even maybe both if need be. But you only need one. Distress that is in excess of what be expected from the stressor. So let's say somebody loses their job, they have to find a job someplace else, and then they end up finding a job on the other side of the country, and they have to uproot their entire lives and go to go out to that job. That can be distressing in and of itself. So you as the clinician need to think about, is the stress or the distress that they're feeling, is that out of proportion with what they should be feeling? So that's a murky area. And there's going to be impairment in their social, academic, and occupational functioning. So you're either looking at distress or impairment. The stress-related disturbance is not going to meet the criteria for another mental disorder, so you have to rule out anxiety disorders, depressive disorders, trauma-related disorders, all of them. And also, this is not an exacerbation of something that they already have. So, if they have an existing psychological disorder, is this adjustment disorder, or is this just that other disorder that they have, like generalized anxiety, that is just irritated because of some kind of stressor? Also, the symptoms that they have are not representative of bereavement. We do not diagnose grief. Grief is not a pathology. So you have to remember that. Once the stressor is terminated and resolved, the symptoms are not going to persist for more than 6 additional months. So it does take time for people to wind down and resolve their distress or their impairment. Now, you can specify whether it's acute or chronic. If it's acute, the disturbance lasts less than 6 months, chronic if it's more than 6 months. And then you have to determine the subtype of the adjustment disorder, because that will ultimately lead to your coding. Typically, the subtype is people are going to come in with a depressed mood, they're going to come in with anxiety, or a combination of anxiety and depression, maybe or a disturbance in conduct where their behaviors are grossly have grossly changed out of what's normal for them, and also or possibly even with mixed disturbance of emotions and conduct. So they might have depression, anxiety, and their conduct has been affected, or it's unspecified. So part of determining the correct coding for adjustment disorder is going to be understanding what kind of symptomology they're coming in with. Differentials, of course, you're going to want to rule out anxiety, depression. You're going to rule out stress, trauma-related disorders such as acute stress or PTSD. Psychological factors affecting medical conditions, and then also just normal stress reactions. Is this pathological? Is this diagnosable, or is this not? It can be comorbid with many medical conditions and also many mental conditions. Okay, last we have the other specified trauma and stressor-related disorder. Once again, this is just a catch-all for folks that do not fit into any of the disorders that were reviewed today. And sometimes this is the best way to go. All right, well, that's it for the trauma and stress-related disorders lecture. I hope this has been helpful for you. If you have questions about this lecture, any of the content in it, please reach out. If not, have a great day.